Recording now. Go.
Brilliant. Okay. Thanks, Nat. Thanks, Olwyn. I'll just start. My name is Leanne Ellaway. I'm a social work lead that focuses on perinatal and substance misuse for Avon and Wiltshire Mental Health Partnership. So I'm going to be co-facilitating with Jools today. I'll just hand over to Jools to
Hi everyone, my name's Jools Granville, and I'm going to be giving you a little bit of an overview from the patient perspective today.
Thanks, Jools. Nat, sorry, my it keeps muting me. Someone keeps muting me, or I'm doing something just before. Can people hear me now?
Yeah, we can hear you, Leanne.
Okay, fine. Brilliant. Okay, so there's a presentation today. It'll probably be about sort of 40 minutes and we'll have time for some questions. I'm just going to start by looking at the objectives of today's session before I hand over to Jools. So Nat, if we could have the first slide, please. Oh. Brilliant. So if we just, lovely, thanks, Nat. If we just go on, sorry, to the second, yeah, the aims and objectives, great. Okay. So this is to understand the role of the perinatal mental health team and how to refer, to understand why perinatal teams exist and the interventions that can be offered, because it's quite a change in terms of the existence of perinatal teams and what's happened over sort of the last 5 years. To understand sort of the red flags, the things that make us more worried about women in the perinatal period. And just to say, the perinatal period starts from 12 weeks of pregnancy up until a year after birth in terms of commissioning for perinatal teams. To identify good practice as well as things to avoid, and to have an opportunity to listen to Jools, who's got some lived experience. So I'm just going to hand over to Jools, and then we'll come back to me after that. Thanks, Jools.
Okay, hi everyone. So my name is Jools Granville, as I said, and if I was at work, I'd be introducing myself as, hi, I'm Jools. I'm the Director of Marketing and Communications at the National Composites Centre, which is the UK's world-leading research and development centre for composites. And it's the place where people like NASA come when they need help putting a rocket into space. That's usually quite an easy thing to talk about. What's not an easy thing to talk about is what I'm about to cover now, which is, my name is Jools Granville, and I have 2 children, and both times I had my children, I suffered with postnatal psychosis, and it was pretty life-changing, pretty life-adjusting. So I'm here today to help with Leanne, because I was one of those people that fell through the gaps of the system that was in place. So what I'm going to do is I'm going to explain to you my first pregnancy, which was 9 years ago. I have an 8-year-old, and my second pregnancy, which was 5 years ago, and I have a 4-year-old as a result of that pregnancy. But I'm going to tell you, first of all, about my first pregnancy, which was in the days before perinatal mental health teams. So I was in my late 30s when I got pregnant the first time. It was a planned pregnancy, and it was something that we really, really had wanted for some time. And when the pregnancy began, I was very sick at the beginning, like a lot of people are, hyperemesis, had to go to hospital and be put on a drip at 1 or 2 points. But, you know, it was a fairly normal looking pregnancy from that perspective. Went to my midwife, got myself signed up for all of that, got the big book and all of that, started reading about the size of your baby, you know, as the size of a pea, as the size of a grape, as the size of at one point it was at the size of an avocado, and I always thought an avocado was a lot smaller than a pineapple, but there you have it. But by about week 22, I started to feel really, really bad. So I started to get intrusive thoughts to start with, and then it started to become more of a depressive kind of feel. And then the anxiety kicked in. So I found myself in this really strange mixed state of just being incredibly worried about everything, but feeling far too stressed out to actually deal with it. So everything felt like too much. I was working at the time, so I thought, well, obviously work's quite busy and I've got lots going on. But it got worse and worse and worse. And I became incredibly emotional. I became incredibly neurotic. And things that wouldn't normally bother me started to really bother me. And by Christmas time, I was a bit of a mess. So we spoke to my midwife. And because I have a history of having had depression when I was younger, my midwife was like, right, okay, I'm going to refer you. And she referred me to a consultant at the hospital who was incredibly kind. Wasn't meant to be covering me because there wasn't a proper perinatal mental health team at that particular point. But she talked me into accepting some medication, which I did. And that held me for a few more weeks. As it got closer and closer to my due date, I started to slip some more. And so I stopped sleeping at night. I started worrying about things like somebody breaking into the house. And I would lie awake at night listening for the sounds of footsteps coming up the stairs. I had really bad dreams when I dreamt, really very intrusive thoughts during the day, lots and lots of worries about the baby, lots of worries about the world. There was a lot of stuff going on in my head. By the time I went into labor, this was kind of very normal state for me. I was very, very up and down and up and down. Very normal labor. Well, I say very normal. Baby arrived quickly. I was in hospital within 20 minutes of having had my first contraction, and the baby was born an hour later. So, that was quite a quick and easy birth. And then that night, lying in the hospital, I didn't sleep. I was in a four-bed bay in St. Michael's Hospital in Bristol. And every single time one of the dads or one of the mums kind of went past, I started to get really scared. And that fear got bigger and bigger and bigger until it was completely unmanageable. Until I started to really believe that somebody was coming to take the baby away from me. And I was literally fight or flight. So I found myself crouched on the bed, holding the baby to me. And nursing staff found me like that when they came in just to check on me and do observations. They tried to calm me down, tried to get the baby away from me. I was having none of it. At which point they decided that it might be a good idea to ring my husband and see if he wanted to come in and spend some time with me, which he did. I was moved onto a side ward where I stayed for 5 days, and it got worse and worse and worse, to the point that I had a day where I attempted to leave the hospital with my baby to get away from them and had to be stopped. I'm really pleased that they did manage to stop me, because I'm not sure what would have happened, because I had, by this particular time, voices in my head. And I'm sorry, I'm feeling quite emotional about this. Usually I can tell this story without getting emotional. The voices inside my head were particularly cruel. There were 3 of them. The first one was my own voice, but it wasn't a very kind version of my own voice. It just basically told me I was stupid and that I couldn't do this and that I didn't deserve to have this baby and that somebody was going to come and take it away and I should understand that. And it was a really kind of matter of fact kind of horrible voice. The second voice was just a bit scary. It was a childlike voice, very, very much like the little people in The Wizard of Oz. I can't remember what they're called. And it literally counted. It counted from 1 to 100. And when it got to 100, it said, and again. And that's what went on continually inside my head. And that was whilst I was awake and also whilst I was asleep, this constant counting. And the third voice came in now and again, and it was much more of a critical voice. And it just basically told me to do things. So go to the cupboard, open the drawer, take out the knife, sharpen the knife, put the knife into your left vein and pull. And it just kept repeating things like that to me. It said things like, the Clifton Suspension Bridge is a really, really good spot. How many people have thrown themselves off there? And it was just horrific. This was all whilst I was in hospital. But the interesting point about it was I kept telling people about these things. And they said things like, your milk's coming in. That's why you're so emotional. it's really normal when you've not had much sleep to sort of think things that aren't necessarily there, but you'll be okay. I was discharged from hospital after 5 days with these voices inside of my head, which by this particular point, I decided, since nobody believed me, that I wasn't going to tell them anymore because they were going to take this baby away from me. I got home. Midwives came round. We told the midwives that I was incredibly anxious, very, very upset, terrified, utterly terrified. They said, it's normal. You're in your late 30s, you've tried for a baby for a long time. It's going to be quite a challenge for you. It's going to be a bit different. My husband took me to the GP. The GP said, you worked full-time professionally beforehand, didn't you? Yes. I see a lot of women like you. It will be a big adjustment, but don't worry. Meanwhile, the breastfeeding wasn't going very well. And I ended up with mastitis in both breasts, and I was not particularly well. So the next trip to the doctors was, well, clearly the way that she's having these hallucinations, it must be part of the fever of mastitis. So here's some antibiotics and off you go. This went on for weeks and weeks, with me getting worse and worse and worse. I wouldn't let my husband anywhere near the baby. All the while, though, if anybody saw me out and about, there I was, out with the baby in the pram. We were out from 8 in the morning. Hi everyone, everything's fine. People would come around to the house. I'd have baked banana bread. I'd have done brownies. I mean, it was literally, my kitchen table was just groaning with things that I brought. The house smelt wonderful because I'd gone around and bleached every single surface, and then had gone around again with lemons to make it smell better. I didn't sleep at night. I wouldn't let my husband anywhere near the baby at night. I stay awake just watching her. And occasionally I would fall asleep, and then I'd find myself waking up and just being absolutely horrified that I'd gone to sleep. The person who saved my life was actually a health visitor, because she came around to see me, and I did my whole everything's fine Susie homemaker thing, offered her biscuits, offered her all these things that I'd made, and she just started to ask a few questions about all right, so you made all of these, it's only 10 o'clock in the morning, did you make them yesterday? Oh no, I made them through the night. All right, okay. And she just asked me the right questions in the right way. And then she said to me, do you know what, Jools, I think that you might need a little bit more help. And she got in touch with the doctor, and the doctor listened to her. And before I knew it, they managed to organise for me to have a psychiatric nurse come out. Psychiatric nurse came out, sat down and talked to me, listened to everything I had to say, and said, sorry, kiddo, we've only got 4 beds in the mother and baby unit, and you're not quite ill enough to take one. So what we'll do is we're going to give you the name and contact details of a charity. They do coffee mornings each day for new mothers who are struggling. It's an organisation called Mothers for Mothers, and they do phone calls. So it was something, but it probably wasn't what was needed. The health visitor didn't let this go. She was rather amazing, and my husband obviously was also rather amazing. And between them, they decided that that wasn't good enough. And so it resulted eventually in my husband going into the doctor's surgery with me and being quite bolshy and saying, look, we're not leaving here until you organise for there to be another consultation, because my wife is just in a dreadful place. By which point I was seeing things as well as hearing things. And I was in an awful, awful position. I absolutely believed that somebody was going to come and take this baby from me. And if any of you had tried to walk in to even take the baby from me, well, it was either you or me who was going to get really seriously hurt. It came to an absolute crisis point, I think, at the point where, whilst waiting for somebody to come out to see me, I started hearing the voices in my head, and they were all 3 of them telling me to go to the drawer, to take out the knife, to sharpen it. And I stood there with my baby in one arm and this ridiculously sharp knife in the other arm. And the voices in my head said, stab your husband. He's going to try and take the baby from you. You need to get rid of him. And it was at that particular point I decided that I was not going to stab my husband, but there was no point in me being alive anymore. And that's when I eventually got taken to the mother and baby unit, where I spent, when I say 8 months of my life, about 8 months of my life. I then spent the next 2.5 years coming back from it. Took a long time. The psychologists were great. The perinatal, the nurses who came out, the psychiatric nurses who came out and looked after me every day were amazing. But it took a long, long time to come back from it. This is a pretty stark story, I appreciate, and I know it's a lot for you all to take in, but I'll come back towards the end of this presentation, and I'll describe to you what happens when the interventions are actually in place. And you'll be pleased to hear that it's a lot nicer story. You're not going to have to sit through that again. Leanne,
Thanks,
over
Jools.
to you.
Thanks, Jools, for that. Okay. Nat, can we just come on to the third slide, please? Brilliant. Okay. So just Jools spoke a little bit about mother and baby units. And just so people are aware, mother and baby units are not places whereby people go for sort of parenting assessments. They are, there's 22 actually now in the country. So we've had more opened up year on year. There's now 19 in England, there's 2 in Scotland, and there's 1 in Wales. There's 22, and they are for people, they, you know, the purpose is to keep mums and babies together, and it's for women in an acute mental health crisis. Okay. So just to let sort of people know that. Okay, so this is the Bristol, North Somerset and South Gloss perinatal team. Okay, it opened on the 6th of March 2017, and I was just thinking a little bit about this. And you know, 5 years ago, in only sort of 2016, 40% of the country did not have a specialist community perinatal team, and now all 44 areas in the NHS areas in England all have a community perinatal team. So the Bristol one was opened in 2017. Okay, it's a multidisciplinary team. What I mean by that is that it consists of consultant psychiatrists, specialty doctors, nurses, social workers, occupational therapists. Really fortunate to have nursery nurses and a parent infant psychotherapist. And I'll come on in a little bit to talk about the interventions that are offered by the different disciplines amongst the team. I think it's really important to say we're not a crisis team. So it's 9 to 5, Monday to Friday. Okay. And if people are experiencing a mental health crisis, then there is the intensive team. It's the same as the crisis team. Sorry, it's just different terminology. So just to sort of let people know that. And in terms of sort of eligibility and criteria, so many women will be given an assessment. It's a specialist assessment, a specialist perinatal assessment when we think about the red flags in the perinatal period. But it's for women with severe mental illness. So this might be people that are perhaps at high risk of deterioration post-birth. So perhaps people with a diagnosis of bipolar or schizophrenia, but also people with sort of a new onset of symptoms. So, you know, where there's evidence of that mental health deterioration. And I'll talk a little bit more about the red flags. And that's the email address and the telephone number. Do you want to move on to the next slide? No. Brilliant. Okay. So this is why perinatal teams exist. Okay. Is that it's all about early intervention. Okay, so that is about, rather than waiting till people become very unwell and very unstable and the risks are really high, perinatal teams are about early planning. So for example, a lot of the work that's done by the perinatal team is it might be about trying to support a woman perhaps to start some medication or have some psychological interventions before things get to a crisis point. Okay, we know in terms of high risk of suicide, it's the leading cause of death for pregnant women. Okay, and that pregnancy does not protect against maternal mental health. Okay, and some women will often see the first onset of mental health problems during pregnancy. The other thing is it's about a risk of relapse. So we know that people who have got a history of mental illness or had a history of psychosis, okay, the risk of relapse post-birth is extremely high. Okay, so so again, it's about one of the pieces of work that we do with everyone that has a perinatal key worker, so everyone on the caseload, is we do something called a 32-week maternal mental health meeting, okay, and that absolutely looks at the risk of relapse for that woman post-birth. And what it does is it will tell other professionals, maybe health visitors, midwives, family members, social workers, about what some of those relapse indicators might be for that lady, okay, so that then we have that multi-agency response with social workers then ring up on midwives and say, do you know what, something's just not quite right, so and so's pacing up and down, or they're a little bit agitated. The perinatal team can go in quite quickly to try and sort of help reduce the severity of that relapse. There's also an acknowledgement about sort of specialised support and interventions, is that women with perinatal illness, their needs are best met by specialist teams, and the evidence for that is around sort of good outcomes for mums and, you know, for mums and children. So it's that they need very specific things and sort of generic mental health teams can offer. Next slide, please, Nat. Okay, so I just want to talk a bit about, so this is quite sort of a basic presentation from my perspective around perinatal mental health, but I guess I just sort of, and I'm not expecting that people go away from here and are sort of experts in assessing this, okay, and the absolute key to working with women in the perinatal period is that multi-agency working, okay, but there are some things that professionals can look out for, okay, and these are your real red flags. These are your, you know, these are the things that we really worry about in the perinatal period, okay. So and as I said, that might be from 12 weeks of pregnancy up until sort of a year after birth, okay, but the risk is at its highest point immediately after birth. So we need to think about new onset of violent thoughts, okay, so women that have not experienced these thoughts and then suddenly they do, okay, hanging, drowning, suffocation, okay, women that are telling us that they don't feel bonded, okay, so that might be that the baby was, you know, perhaps an unplanned baby, it might be a child that's conceived via rape, but so, you know, for whatever reason, maybe they miss antenatal appointments, that that they are worried about having baby, and they're concerned about that. A change in mental state in the perinatal period, or a new emergence of symptoms. So if we got a referral, just thinking back to the slide that talked about eligibility and criteria, okay, if we got a referral that talked about any of these things, but particularly around change in mental state in the perinatal period, we would absolutely be offering a specialist perinatal assessment, okay, because that's one of the red flags. So, you know, say for example that someone says that they haven't got a history of mental illness, no concerns, they've suddenly got pregnant, they're 6 months into the pregnancy, and perhaps feeling very low and depressed and anxious, struggling to go out, struggling to sort of visualize life with the baby. So if something changes, and people might have heard the phrase of a postpartum psychosis, okay, and a postpartum psychosis is people are at highest risk of that immediately after birth. The risk slowly decreases as the time passes, okay, but actually what's really, really important with this, it is a psychiatric emergency, okay, and you know the treatment and responses need to be quick. So if you're working with a family and maybe a family member or partner is saying that they are worried, you know, about someone, and these changes, I was sort of thinking about this, you know, how do you sort of describe this to people? It might be that actually it's really, really apparent that someone is very poorly, okay? And that's probably more about, you know, when you can see people responding to voices, for example. But actually it's just, you know, perhaps someone just acting a little bit out of character, okay? And that's the bit we don't expect people to sort of assess it, but that's about picking up the phone and saying, do you know what? Something just isn't quite right, okay? So they're your perinatal red flags. Nat, could you go on to the next slide, please? So I just sort of wanted to have a think about these. Sorry, for people, Embrace is mother and babies. It's reducing risks through audit. Okay, so you've just seen that just at the bottom there, 2015 and 2018, and it looks at the outcomes of previous confidential inquiries into perinatal mental illness and deaths. So sorry, Nat. Yeah, brilliant. Okay, so just really wanted to sort of give you sort of 3 things to think about. Okay, so women are 23 times more likely to experience a psychotic episode perinatally than at any other times in their life, which I was sort of quite astounded at when I thought about that. More than 1 in 10, more than 10% of women develop a mental illness during pregnancy or in the first year of having a baby. And that's why, if we think about the previous slide about red flags, is people don't need to have a history of mental illness, okay? Because for some women, they will develop that, okay? And I think Jools sort of touched on this. And it's by no means unusual from my experience of working with families. It's 7 in 10 of women underplay the severity of their mental illness, and I think Jools gave a really good example about sort of all the baking that she'd done, and made out that actually things were going pretty well, really, and it was only when the health visitor asked some additional questions to understand what was going on that was understood. So okay, Nat. Okay. The majority of suicides are by violent means and almost evenly distributed across the postnatal period. 13% of suicides occurred in pregnancy. And then we come on to methods of suicide in 2018: hanging, falling from a great height, drug toxicity, being hit by a train, and suicidal stabbing. Okay, so that hopefully gives some understanding around sort of the perinatal red flags when we talk about new violent means of suicide. Okay, and thoughts? Okay, Nat. Okay, so I just want to have a think about, professionals are really busy, and I just sort of wanted to have a think about sort of good practice around, perinatal mental health. Okay, and I think, first and foremost, it's really important to what we do with all families. Okay, actually, it's about gathering information, listening to what the person themselves is telling us. Trying to explore what family members think, people that are close to them, people that will have been living with them 24/7, observations. Okay, so actually, if we're just not sure about something, and perhaps we speak to the husband, for example, and they might say, well, actually, she's just acting a bit odd, she can't really sleep and her sleep's always been brilliant. And then people often say, but you've got a new baby and that's perfect, that's perfectly normal. I think it's really important to listen to what family members and the person themselves are saying, and try and gather and assess that, really. Just ask sort of open questions. How long's that been going on, for example? Is that something that's just occurred in the last few days? Was it happening in the hospital? How was the birth? Yeah, okay. Is it new? Any medication? So be transparent and explain your thinking. So actually, if we're worried about what we're being told, if we're just not sure, if we're thinking of a conversation with the perinatal team might be helpful to talk to the family about that. Okay. The thing that's different around sort of perinatal mental health is we have a low threshold for referral. Okay, and what I mean for that is that the threshold for an acute psychiatric admission, okay, for a woman, for example, is very, very high. But because of the fluctuations, we'll often talk about sort of it can be a really rapid change in mental state in the perinatal period. Okay, and because the risks are so high, we have a lower threshold in order for perinatal teams to accept referrals, but also in terms of thresholds for mother and baby units. Okay. So assess and reassess, and I think, again, sort of Jools touched on that. Really sort of think about, do we think we're getting a true picture? Because, for lots of reasons, perhaps people won't feel able to be as sort of open and honest, whether that is sort of, as Jools, said, about the fear of sort of someone taking the baby, or maybe it's just not really knowing what's going to happen if they do tell someone, or actually just how frightened they are living in that, in their own mind and with their own thoughts. Okay. And just consider the impact of stigma. Okay. And I've just made a little comment there about sort of the issue of consent. So, you know, in 99% of cases, we will ask for consent at the perinatal team, okay, and that's about doing things with rather than to, okay. But actually, if you think someone is very poorly, okay, and the family member saying they're very poorly, you know, anything, as I said, postpartum psychosis is a psychiatric emergency. The quicker someone intervenes, the better. You still might wish to have a conversation with the duty worker at the perinatal mental health team. There's a duty worker, sorry, just to say 9 to 5, Monday to Friday, okay, that you can just ring up and run things by. So, okay, next slide, Nat. Okay, all right. So I've heard a lot of the idea of sort of a lack of sleep, difficulties feeding, baby blues. Okay, I think it's really, really important that that we don't sort of just come up with reasons as to why someone might be acting like that or behaving like that. Okay, if we don't know. So really listen to what the struggle is and what the concern is. Okay. I've heard it a lot around sort of one of the triggers for relapse for certainly, for quite a few women actually that we've worked with in the perinatal team has been around breastfeeding. People have had a real sort of desire to breastfeed and they can become very distressed when, for whatever reason, that doesn't happen. So it can be a trigger for a relapse in terms of someone's mental state. Okay, so don't underestimate the importance, of that with people. And I guess, there's something here about it is very normal, isn't it, if you have got a newborn baby, for your sleep to be affected and for you to get less sleep. But it's it's the impact then that's having. Okay, so we've talked about don't make assumptions, don't ignore the risks, and that sort of comes into your ability to assess and risk assess and ask questions. Make promises. It might be that you leave there and you're sort of thinking about how concerned you are. Perhaps you're not sure. But as I said, the earlier perinatal teams and mental health professionals are aware of this, the more of that preventative work that can be done. Okay. Next slide, Nat. Brill. Okay, so I just wanted to talk a little bit about, so these are the various interventions that can be offered by the perinatal team. Okay, so let's just start. So a specialist assessment. Okay, so the difference that a perinatal assessment will have to sort of a generic mental health assessment, for example, is that we will ask very specifically about the perinatal period. Okay, so we will ask about whether baby was planned or unplanned, how you feel towards that baby, any thoughts around sort of depression, anxiety. We also do a couple of questionnaires with people, which is their assessments around assessing the scale of depression, for example. So the PHQ and the GAD. I can circulate those at the end if people just want to have a look. And we'll also ask about sort of new onset of symptoms, history of any mental health issues, history of suicide, self-harm, and any family history. Okay, so that will be the purpose of the specialist assessment. And then what happens as a result of that is it might be that someone needs to come onto caseload and be allocated a key worker. It's those women that have the 32-week maternal mental health plans. And actually that is about, so the people we would take onto caseload is if the risks are very high of either a relapse or the perinatal red flags are present, or if they have if we can be really clear that these issues are perinatal related and that they don't predate the perinatal period. Okay, and the reason I talk a bit about sort of predating the perinatal period is that some women that come on that are referred to our service will already be open and working with other parts of mental health services within Avon and Wiltshire Mental Health Partnership. So I'm sure people are aware of sort of recovery teams, for example, that are in North, South and Central Bristol. So sometimes if perhaps someone has a history of sort of very long-standing trauma and has become pregnant, what happens in that case is that we will go in alongside the recovery team. So our role, the perinatal team, will focus very much on the perinatal issues, and the recovery team will also stay involved because they've got that long-term relationship with that woman. Okay, and that's the bit at the bottom that I talk about, adjunct working. So we do preconception clinic and advice to GPs. We have a lot of women that refer to us that as soon as they become pregnant, they immediately want to stop medication. Okay, so we will often get GPs ring us up and say someone's 12 weeks pregnant, they're on an antidepressant, they're desperate to stop. What would you advise? Okay. So and also we would advise on sort of more complex, so perhaps women with a diagnosis of bipolar who perhaps are on a number of different medications, about what might be the best sort of pathway. And all this would be done in collaboration with the woman and their family. Okay, I've talked about the 32-week plan. Referrals and signposting. So if we feel alongside the family that we've tried to do everything to support someone in the community, and perhaps someone is becoming more unwell, or perhaps someone is sort of a period of trying to get them stable on medication. Okay, we might think about signposting to a referral to the mother and baby unit, signposting to other charities like Bluebell and Mothers for Mothers, or it might be sort of even further afield, things like Vitamine's Freedom Programme. So we've got a psychologist who offers one-to-one work around, for example, coping with emotional dysregulation, cognitive behavioural therapist, and she does group work and one-to-one work. Parent-infant works, we're really lucky. We're one of the few, one of the few community teams that does have a parent-infant psychotherapist, and they hold a caseload, and we'll go in, and it might be quite a short piece of work for sort of 2 or 3 sessions, or it might be for several months. Okay, and the parent-infant worker is also trained to provide something called video interactive guidance. Okay, if people sort of know about that, but it's whereby, obviously with parents' consent, is that you go in and you video some of the interactions between mum and baby, and it can be really effective when mums feel that the bond is sort of really strained, and then you watch the video back and you really sort of scrutinize it and point out what's going well. Did you see him or her smile at you? Okay. Nursery nurse supports. We've got nursery nurses in the team that can go in and offer interventions like baby massage, for example, advice around breastfeeding, weaning, refer to the lactation specialist. Crisis and contingency planning. Okay, that's the bit about the risk of relapse, and having a think about what the risk of relapse is. What might you do if it's out of hours? Would you ring the crisis team? Giving numbers for the Samaritans. Who else is in the family support network? The other thing I would say here is I'm not ignoring the role of men and fathers and partners. Okay, we will also signpost to, for example, Mothers for Mothers, to ensure that partners' needs are met. Medical interventions, we might think about, for example, mental health act assessment, starting people on medication. Talked about adjunct working. Something we've recently started doing is co-facilitating a freedom programme specifically for women in the perinatal period. And some of the thinking about that is that actually they're in a very different place in their journey to other women. So next slide, Nat. Okay, I'm just going to take a pause and hand back over to Jools, if that's okay. So you can take the slides down, Nat, if that's, thank you. Okay, Jools.
Great, thank you. So I left you with me trying to recover from my first pregnancy. In between that and my second pregnancy, I was actually diagnosed with bipolar disorder, which didn't come as much of a surprise, because if you think, I thought back to my family history, and there's definitely some cases of bipolar disorder within the family. My mother had postnatal psychosis. My aunt had postnatal psychosis before her. None of this was picked up in my first pregnancy. But I'm very pleased to say that within my second pregnancy, the Bristol Perinatal Mental Health Team was being formed. So at the very beginning of my pregnancy, it was still something that was about to be put together. And so I was rather lucky that I was seen by the very same consultant who had looked after me 4 years earlier. And she said to me, look, they're putting together a perinatal mental health team. And until that particular point, me and my team will hold you. So it was a little bit odd because I got rather poorly quite quickly because of the medication. So I was taking a range of medications that were holding my bipolar in place, and I was feeling better than I had done in years. But obviously those medications and pregnancy don't necessarily mix particularly well. So I was admitted to hospital and I was on the mother and baby unit, the mother and baby ward. So basically half of the ward had newborn babies. I was at the other end of the ward with the people who were waiting to have their babies for whatever reason. So if they were there to have their pregnancy induced, or if they were there because they were supposed to have bed rest. So it was a very strange place to be quite early in a pregnancy, because I knew that I wasn't going to be leaving the ward with the baby in arms, certainly not in sort of like 14 weeks pregnant. But they were absolutely brilliant with me. So they looked after me through the hyperemesis, the fact that all of my drugs then came out of my system and made me rather poorly. And they held me until the perinatal mental health team was actually put in place. And the difference between the two pregnancies is like night and day. I can talk to you about this pregnancy with a big smile on my face, because although I got ill, and I got ill in pretty much the same pattern, week 27 was where it all kind of went really, really quickly. So I didn't feel brilliant for the first 20 odd weeks, but week 27 is where everything went downhill. The voices started kicking in, the delusions started kicking in. I started to believe that I was in control of the weather, which is something which is quite normal in people with bipolar disorder. They believe that that the television's talking to them sometimes, or that they sort of godlike feelings. For me, it was I could control the weather, and because I wasn't feeling very good, you all had some awful weather that season. But luckily, the perinatal mental health team just had me. I had a person who looked after me full time, and then there were other people in the team who I got to know, who came out at various other intervals. And so between week 27 of my pregnancy and giving birth, I'd met a team. I had them all around me. I had the right medication in place. I had some coping mechanisms. I had somebody I could talk to. And as it got closer to the actual birth and I got more poorly, they increased the amount of visits to my home. And the thing that was brilliant about that was the fact that I wasn't in a hospital ward. I wasn't sitting there watching other people with their babies and having what that does to your head going on. I was at home. I was still trying to work, and they supported me very much in that decision. So this allowed me to have more of a life around my daughter as well, who was 4.5 at that particular moment. And they provided support also to my husband and to my family, who, of course, having gone through this before, were all a little concerned as to what could happen next. I think it's really safe to say, and I talked to my husband about this morning, like we just felt held, and that was the most important thing. Went into labor, gave birth, a very, very fast birth again. This time, not quite as nice a birth. I actually had a psychotic episode in the middle of it. So I was in labor, but I believed that I was being tortured. I didn't think I was pregnant at all. I didn't think I was in labor, clearly. And I thought I was being tortured, and I kept begging my husband to make it stop and apologizing for whatever it was that I had done to make people treat me this way, which I think was pretty horrible for him. And probably you'd be pleased to hear that we haven't got a third child, and there's probably a good reason for that. I think it was probably that psychotic incident in the middle of there that was the final death knell on that one. But after the baby was actually born, handed to me, I didn't have any problems either time in recognizing the baby as my own. A lot of people do have that. With me, it was just pure terror that I just could not do this. And the feeding was impossible with both childs. Difference between the first and the second was that the first one, it was very much the breastfeeding Nazi policy of, you will breastfeed at the hospital. We don't offer any formula. You know, it was very, very much a breastfeed or nothing kind of mentality. Whereas the second time round, because everybody knew what was going on, there was a plan in place. When I gave birth, I was taken straight away to a side room where I wasn't surrounded by men, because I was terrified of men. And I actually, on the night after the baby was born, the nursing staff took the baby away for a couple of hours and let me have that extra bit of sleep. The impact on breastfeeding was a bit difficult, because that did mean that quite early on my milk was coming in, but the supply was being slightly interrupted. But ultimately, we knew as a team, and we'd sort of agreed, that I was going to have to get onto some seriously hardcore medication pretty quickly. And so breastfeeding for me wasn't really an option for very long. I managed to do it for the first 6 weeks and keep the major medication at bay, because that was something that I felt really strongly about, and they really supported me to that. I probably got a little bit more poorly because I did that, but it was the payoff, and we'd agreed it, and I was supported in that choice. 6 weeks, which I know is such an arbitrary number, but in my head, 6 weeks was the time. At 6 weeks, onto the hardcore medication, and because I'd been quite poorly, I was on the mother and baby unit again by this particular time. But I didn't stay there as long. I did about 4 months this time. And a lot of that was about me coming home, being supported at home, and then going back in. So it was a completely different experience. Same illness, pretty much same symptoms, but by a year, when I'd had the perinatal mental health team look after me for that year at home, I'd gone back to work, and I was feeling so much better. And I'm sure you can tell between the two stories just the difference in how I feel about that pregnancy and about that time. You know, the difference between how I feel about the babies is no different. I love them both very, very much. You know, there's enough love in your heart for everybody, isn't there? But in terms of the experience, having that perinatal support in there just made every bit of difference to me. It made every bit of difference to my family as well. So, you know, I am the poster girl for why you need proper perinatal mental health care. But I think the message I want to leave you with is, from that first conversation that we had, anyone can save a life, absolutely anyone. And the health visitor who actually, you know, did save my life, she didn't stand next to me on a bridge and talk me down. She didn't take a knife from my hand. She listened, and she was inquisitive. She recognized there was something that wasn't quite right, and she went with that. Now, if she'd been wrong, what bad would have happened? You know, somebody would have come out and checked and said, no, she's fine. It would have been just a little bit of somebody's time, but she was right, and I wouldn't be here without that. So that's what I'm going to say to you. You guys can save a life every day.
Thanks, Jools. Thanks for that. Nat, can I just go back? I think there's just sort of one slide left before we come for questions. Brilliant. Okay. So I think, I mean, these slides are available. Nat, that's right, aren't they? Have I got this?
Yeah, they are available. They'll go up on the website, sorry.
No, that's fine. Great. Okay. So there's the parent, you know, if you do a referral, there's the email address to send it to. Now I could probably add the actual referral form, which might be quite helpful to people. But also, as I said, we do have a duty line. So, you know, you can pick up the phone. That was on the first slide, the phone number, and just run it by someone on duty, you know, and even if you haven't got consent, you can do it anonymously, have a conversation, tell us what you're worried about, and we can have a think about that with you. Okay. Just the next slide. Okay, brilliant. Lovely. I think we've got a bit of time for any final questions. Brilliant.
Olwen, can you pause the recording for us, please? And then we'll open the question and answer session.
Yeah.